Mm. Hi, Dr. John. Are you there?
Hello.
Yeah. Please, can you please convert me into co-host and also just follow, the Professor Barbara's guideline.
I'm sorry.
Yeah, can you refer to the message I have sent to you on the messenger? Please make me co-host now.
Okay, you sent me a message on the messenger?
Yeah, exactly.
Okay, okay.
Yeah, hi. Please make me the co-host now and just keep only the speakers in the panel.
Weapon. You're playing the guitar,
Oh yeah. Maybe
Okay.
some live show.
huh? You got your camera working today?
Yeah, exactly. I just cut it off right now.
Dr. Kabulo, are you there?
Hi, will you make me co-host now and just I've also just keep the speakers in the panel only because Professor Barbara doesn't like it to see everyone in the panel.
Okay, now listen, you're gonna be the announcer. I'm just gonna introduce you.
Yeah, exactly.
Okay, it's
I
your
will
show.
follow it.
It's your show and you run it and you do whatever you need to do, okay?
Yeah, thank you. You'll be
Okay,
around in
I'm
30
not
minutes.
even gonna be in the screen. I'm just gonna 109876. Hi, I'm Nor from
Oh, sure.
Neurosurgical TV. I'd like to introduce,
Yeah.
you just start, okay?
Okay, well, please make me the co-host now. I'm just messaging Dr. Neela.
Oh yeah, I gotta make you co-host, right?
Yeah, exactly.
Dr. Kabula, you there?
And we are going to stick to the speaker only panel, right? Because Professor Barbara will not like it.
Well, let Byron be.
Yeah, you know that. He's joining in, I think, shortly because let me check. First, Dr. Andrea Bar will come in. She will deliver a 1-hour lecture. Then Professor Barbara will come
Yeah, you
in.
can let the people in.
Yeah,
You know how to do that, right?
Yeah, exactly.
Okay, I'll let you go then. Now, keep an eye on that.
Yeah, exactly. I'm just looking at that. First of all, Professor, Anila Dabar will walk in, and I think it will be followed by Professor Borba. After that, Professor Tarakan will come, and I think the third professor.
I don't have to know the details, nor you just run it. And if you need to, if you want to take questions, take questions. If you don't want to, you don't want to, okay?
Oh, we have got to mute people. Yeah, I think it's okay now. Yeah, okay. So how is everything going on? I think people are joining in. Slowly, we have got 3 abstracts, and we have got another video abstract that has been sent by the chairperson of WINS Philippines. I think I will play that video. She will join in also. Dr. Bennett, please don't.
Yes.
Yeah, you just have to follow. I will be, I'll be roasted.
You're roasted.
Yeah, I'll be roasted.
You're roasted.
I have to. Yeah,
You getting yelling this morning?
Yes, I have to follow the command. And I totally agree to that too because I have seen things happening, and we have to how to keep everyone. I think we have to keep everyone mute so that you do not have that.
We're gonna have a good crowd.
Yeah, it seems likely.
You did a good job promoting.
Thank you. I think people were
You
quite
started
interested.
a while ago, right? Yeah,
Yeah.
because no, I really don't understand what you're doing as far as e-posters and stuff. So you just take care of that, right?
Yeah, I'm looking at that.
Okay.
Hello, Dr. Bennett. Hello, Dr.
Hey,
Noor.
Dr. Kabula,
Hi.
welcome.
Thank you so much. How are you doing?
We are all
I'm fine.
doing great. Thanks for joining in.
You know Dr. Kabula, right, Noor?
Yeah, he's a friend of mine. Obviously, I do know him very well. How are you doing, Dr. Kabula? And obviously, I was waiting for you to send me some abstracts. So I think next time maybe.
We almost went
Sorry?
to Africa. We almost went to China together. We got a room, but we didn't go. We both didn't go. We both had problems with
Yeah.
the visa, right?
Yeah, I remember the time you went to Portugal.
That was a visa problem, right?
Yeah.
It was a big issue back then. It was a big issue back then for me as well. So, Dr. Kabulo, I was waiting for you to send me some abstracts. So maybe next time.
Sorry, you were waiting for me?
To send an abstract for TraumaCons, to send me some paper.
Oh, it's okay. No, no problem. I will send my abstract. Just send me the link even on WhatsApp.
Yeah. No. I mean for the TraumaCon, obviously we have the TraumaCon today, so unfortunately we cannot add anything new. But I thought that you would send me. Yeah, actually I thought that you would do that. Yeah. I was actually. Yeah. Yeah. Next time maybe.
Yes, I understand.
Interesting cases. Basically, I think you are now dealing more with the pediatric surgery.
No, I think yes, you have to do everything, right, Dr. Gabolo?
Yes, we have to do everything here this side, because I remember last time when I presented, we are few, so we are dealing with everything.
Yeah, you can't say I can't do that. I'm a pediatric neurosurgeon. You do everything.
Yes, but I used to like pediatric neurosurgery because even my dissertation, when I finished, I wrote my dissertation on pediatric traumatic brain injury.
Oh, okay.
Yeah.
Have you done much cystonostomy? Have you done any cystonostomy, Dr. Gabullo?
No, here no.
Okay.
Yeah. But I saw one with Professor Hypcherian.
That's great. But Dr. Kabula is very much dedicated. I've seen him, we've been together for the IBNC, and I've seen him working a lot. Yeah. So he's really competent and he's always looking forward to joining something new. So you've got a brilliant future ahead of you, I'm sure.
See, a lot of those panelists look like they're in, but they're not. There's only two panelists, and it's you and me. That's it.
Yeah, exactly.
And the rest of the people have the privilege to talk, but they're not in the panel.
Yep. We have got the Parkinson's.
Good morning, the Byron and Jorge. Good morning. Well, they have the choice. They have the choice just to watch or.
Dr. Bennett, one more thing. We have got two webcasts in line. The one is the Parkinson's disease webcast, and the other one is the module 3. The module 3, the suggested date for the module 3 is 23rd of May. That will be on surgical procedures.
Yeah, I can't understand a word you're saying, Nora. You have to write it. Text it, please. Text it. In the chat,
I'll do.
Anything important, text me, okay?
It's regarding the webcast. We have got two webcasts to broadcast.
Byron, are you there? I don't know if you can hear me. Maybe you just got it on. Oh, okay.
Hi, Dr. Neela. Hi, madam. Hi, madam.
Hey, Nu, how are you?
I'm doing great, madam. Thank you so much for coming today. I hope you are doing great as well.
Yes, I am. Thank you so much for inviting me. I'm just going to turn my video in 1 second.
Yes, sure, ma'am.
Hi, John. How are you?
Hello,
I
Dr.
haven't seen you.
Hi, Anil.
I'm,
How you been? How you been?
I've been well. I haven't seen you in a long time.
Yeah. I've been doing them still.
Yes.
So how are
Okay.
things in Pakistan? You're in Pakistan now, right?
Yeah, Pakistan's situation is not that great these days. A lot of political issues going on.
Oh, is there?
Yeah. Okay, there I am.
Hi, madam.
Hi, how are you?
Madam, it's a matter of great honor and pleasure to have you here for the virtual conference. We are introducing it for the first time. I think it will work. There is actually a recent study where they have compared the concept of virtual workshop with the on-site workshop, and they said that it was quite good. The juniors appreciated it so much. So I think that it's going to work for us as well.
Hopefully. I hope I can teach something today about neuro ICU to the group of attendees here today.
Wonderful, madam. It's a very important topic. I think that you will certainly do justice to this very important issue. And most of us, we really want to have it, even those who are not in neurosurgery. It is a topic of great importance for even those people who are just acting on the surgical floor as well, because several times we have those patients in the surgical emergencies when we do not have the capacity. So it is going to be something very important for everyone. So thank you so much for coming and for accepting it.
Absolutely. Looking forward.
We've got people joining in slowly right now. So we have got 4 minutes to start.
Same clock as me. Hello, Harshad. Good morning, Harshad. Well, good evening.
Madam, I was also thinking that we should bring the workshop booklet so that it might be easy for people to have a quick reading after it, if you say so.
Sure. I mean, I can absolutely give you my slide presentation, and if you like, you can just use it to teach others. Yeah, create the PDF.
And make it available after the show to our Facebook web page, where we usually upload all the material that is relevant with the conference. Actually, we are also writing a book which is based on all the topics we will be teaching in our 1-year long course. Madam, we have a parallel 1-year long course for medical students and medical residents. We have finished. We are done with 2 of the first modules on basic neurosurgery, and we are going to have the 3rd module on surgical procedures later this month. So we are also working on a book for that one, and I think there will, if you like you have said, if you share that PPT, that will be very, very helpful. So thank you for that.
Of course.
I think we can ask promotion.
Who's the first speaker? Is Anila first speaker?
Yeah.
Oh,
She will conduct the virtual workshop for 1 hour. After that, we will have Professor Luis Borba joining in, and Professor Tariq Khan will speak. He will deliver a 30-minute lecture, and that will be followed by Professor Andres Rubiano.
Okay.
We will have a very short session for oral presentation. Madam, we have actually made a convenient virtual trauma con, very convenient, a very precise and concise type of virtual conference. Professor Barba really believes that a very short webinar is much helpful for people, because because they are interested in taking that very short webinar and listen to everything and keep their focus. And I really agree to that, because it's really convenient for all of us to attend a conference that is not that much long, and it is also easy to replay.
Okay, Noor, the dervish is ready.
Yes,
Are you ready? Are you ready, dervish?
Yeah, I'm ready. We have
okay. Let me get ready. Okay. Ready? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Good morning, good evening, and good night, wherever you really are, because we are dealing with the global conference right now. We are really pleased to organize this comprehensive and concise virtual trauma conference for the medical students, the neurosurgical trainees, and the junior neuroconsultants alike. For the first time, we are introducing the concept of a virtual workshop on neuro ICU care that will comprise of didactic lectures and relevant videos of the procedures and techniques that require demonstration. We are really honored and pleased to have Professor Anila Darbar with us. I think she doesn't need any introduction to anyone because she has been so active in all the neurosurgical educational activities so far. We are really proud to have her. She's the founder and the ex-chair of WINS Pakistan session, the Pakistan chapter, and she has contributed several chapters in different international books, including the Ringachari medium book, what we call as the Alan Wilkin textbook, and there are also her contributions in the research papers, and you'll also see her on various webinars. She has conducted several on-site in-person workshops. Before the pandemic, we had all those privileges of attending an on-site workshop, but of course we cannot do it that much frequently and that much easily, although things are getting back to normal slowly. But it is a matter of huge pleasure and honor to have her today with us to conduct a virtual workshop on neuro ICU care. Madam is right now the medical director of Mukhtar Ashif Hospital in Multan, Lahore. She's a senior neurosurgical consultant there. She has affiliation with the AK Juda Khan University Hospital, Karachi. Madam, now the floor is all yours.
Okay. Thank you very much, Noor, for your very kind introduction. And I really like this idea that WFNS, Dr. Louis Borba, and Noor has put through to do a very concise kind of a conference in which there is a workshop, there are some poster sessions, there are some few didactic lectures. So, within couple of hours, instead of days and weeks of workshops or conferences, you can just get all the information within 2 to 3 hours. And I think these days when webinars are so much in vogue, this is the way to go through. So I congratulate the WFNS Education Committee, Dr. Louis Borba, Noor, and John for organizing this TraumaCon 2020. And without much ado, I am going to start the Neuro ICU lecture. I am going to start sharing my screen now. Okay. Can everybody see my screen?
Yes, it's not full size, not presentation mode yet.
Okay, yeah, there we go.
There we go, perfect.
Okay, great. So today I will be talking about a few very, very important subjects that are essential for every neurosurgeon, whether they are a budding neurosurgeon as a medical student, or they are junior residents, and in fact, senior residents or junior consultants. There are few issues in neurosurgery that has to be absolutely on your fingertips. And it, of course, does not comprise the entire series of diseases and management that includes the neuro ICU. But I hope that this could be a start of a seminar or a series of these virtual workshops in neuro ICU, in which each workshop teaches you one or two components of neurosurgical ICU diseases as well as management. So in this first Neuro ICU virtual workshop, these are the two places that I work, and Noor introduced me about that, and you will not believe that they are actually 883 kilometers apart. How do I travel between those two? It's a mystery to myself as well, but I'm still doing it. So the three topics that we're going to be covering today is, number one is evaluation of a critically ill neurosurgical patient. Second most important topic is how do you manage raised intracranial pressure, especially for trauma and for hydrocephalus. And the third important point we're going to be talking about is all about malignant cerebral edema and how do you diagnose as well as manage them. So the first one is, of course, the evaluation of critical ill patient. And when we talk about critically ill trauma patients, the few things that comes to our mind is, number one is, of course, a road traffic accident or a fall from a staircase or from a height. And that usually results in either a subdural, an epidural, a diffuse axonal injury, a bilateral or contra-coup contusions or frontal contusions. And these are the things that comes to our mind when we think about trauma patients, especially brain. Now, of course, spine is a completely another issue, but a lot can be covered in the brain. So that's why I have only chosen brain right now for the evaluation of critically ill patients. So when somebody undergoes a trauma, usually there is a set of primary and set of secondary injuries. Sorry, my throat is a little scratchy, so I'm going to take it. So for primary injuries, you have skull lacerations, skull fractures. John, Noor, I'm having a little issue with my throat. I'm just going to get a glass of water and I'll be back in a second.
Sure, ma'am.
Okay, I'm back. Sorry about that.
No problem, ma'am.
So first we talk about primary injury. So when patient undergoes RTA, fall from a height or from staircase, they either get a skull laceration, skull fracture, there are contusions, intracerebral hemorrhages, lacerations, and diffuse axonal injuries. And we usually, in the beginning, we start to take care of these primary injuries. Now, the problem is, I wish that if there is skull laceration, we repair and everything goes well, or if there's intracranial hematoma and we take the hematoma out and everything goes well. But unfortunately, for any kind of brain injuries, the moment the primary injury happens, there is a series of secondary events that starts to happen. And these secondary events are due to release of cytokines, inflammatory markers, free oxygen radicals, toxic amino acids, and as a result of which, the secondary injury starts to happen. And this secondary injury usually results in deciding whether the patient is going to have a mortality or a morbidity in the days after the primary injury. And the secondary injury could be due to increased intracranial pressure, hypoxia, hypotension, hypothermia, electrolyte imbalance, etc. Why is my screen not? Okay. So the first important thing is if you have somebody has an RTA and you find somebody like that on a road, what do? So the most important thing in trauma that we learn is that how do you manage before the hospital of a patient? Now, if you are in a first world country and if you find somebody like that, it's easy to just call 911 on your emergent call and your paramedics arrive with an ambulance and they usually have everything, oxygen, ventilation, how to intubate patient, etc., etc. But if you are in a LMIC country or in a really a third world country and you do not have those kind of services readily available, then the most important thing is to take these kind of patients who are unconscious to the nearest tertiary care center. Please don't take them to a small clinic because usually it delays the primary treatment that is required. So usually take them to a tertiary care center, and that's the best thing that you can do. So if, for example, if you are in a first world country and you have emergency paramedics as well as ambulances available, then as you can see, the pre-hospital management is all about taking care of the patient. So for example, putting in oxygen, making sure that the oxygen is fine. You can even put a carbon dioxide monitor. You want to make sure patient is not getting hypoxic, the blood pressure is normal. You quickly assess a GCS by looking if the patient is awake, talking to you, what is the pupillary reaction, with the signs of herniation or not. And if the GCS is 9, you immediately intubate it even before reaching a tertiary care hospital. And then once that is done, the goal is to, of course, transport to a facility that has CT scanner, an MRI, and the ability to treat a neurosurgical patient surgically or measure the ICP. A couple of things that a pre-hospital management also requires is that if there is some sort of other injuries like a long bone injury or a scalp injury or a spine injury, then you either can temporize that bleeding by tourniquet or by applying pressure. And for spine injuries, it's very important that the patient is completely immobilized on a stretcher or on a trauma board so that neither the neck moves, neither the spine moves, because 80% of the spine injuries, secondary spine injuries, usually happen when the patient is moved incorrectly from the site of accident to the tertiary care center. So immobilizing the patient for spine injury is very important. Now, once you have reached the emergency department, the first thing, of course, is ABCD, right? So you do airway, breathing, circulation, okay? And then your primary, secondary, and tertiary survey. For airway, you check the airway. If the patient's already intubated, great. If it is not, and you think there's required intubation, you go for intubation. Make sure that the ventilatory settings are correct. You call, if you have a neurosurgeon, call for a neurosurgeon or a resident to come. If not, if your center doesn't have it, then you have to do a preliminary GCS to evaluate if patient does not have any kind of herniation syndromes that are starting to creep up. Systemic trauma evaluation means that you do a primary survey. You make sure you start from the head, eyes, neck, thorax, chest, making sure the breath sounds are there, abdomen, any kind of long bone injuries. You log roll the patient, make sure there's no spine injuries, and that is usually includes your primary survey. For the neurosurgical services, when the secondary service starts, you have to start your lab work, in which you send your basic chemistries, alcohol levels in case you are if the patient was drunk, involved in a car accident. You require imaging studies like CT head, CT spine, chest, abdomen, pelvis for trauma evaluation. And if you see any signs of raised ICP, for example, there's a pupillary dilatation or there's some Cushing response happening, then you immediately start doing things which helps you to do ICP control. For example, the head of the bed is elevated, head is put in a neutral position. The neck is not one side or other. The sedation and pain management kicks in. You make sure that the patient PCO2 is also in a normal carbic state. You can start IV fluids. You can start mannitol or any hypertonic fluid simultaneously before your evaluation of a CT scan or MRI to know exactly what the situation is. So there are a few recommendations that happens that you require in case there's a trauma patient. So for example, if you such a patient comes to you, he's unconscious, his GCS is about 7, you got a CT scan done, you show there's a diffuse axonal injury. So there is not something that you can, you need immediate operation for. So what are the few steps in the neurosurgical ICU that you need to keep in mind when such a patient goes to the neurosurgical ICU or a high dependency unit like an HDU? The first thing is, of course, you want to start the patient on some sort of a hyperosmolar therapy. So you start the patient on mannitol to control the elevated ICP, especially if you are seeing signs of transtentorial herniation like pupillary dilatation, etc. You can also start 3% normal saline, which actually really helps in the long run. Second thing you have to look for, if the patient is hyperventilating, making sure that the PCO2 is somewhere between 30 and 35. Use of anesthetics also helps in decreasing the brain metabolism. So it helps in decreasing the ICP as well. Commonly used anesthetic is propofol. Sometimes pentobarbital is used if the medical treatment is completely exhausted. There's no use of steroids for brain injury, but there was an initial role in spine injuries about 20 years ago, but it's completely abandoned now. For infection control, you usually start them on some sort of an antibiotic so that they don't have VAP, which is the ventilator-associated pneumonia that usually happens to these kind of patients. And early tracheostomy should be considered. So I have to let you know that in LMIC countries, there are a lot of tertiary care hospitals in which ventilators are not available at all. So in these hospitals, what happens? That the moment the patient's GCS comes and the GCS is low, they immediately do the tracheostomy. And they have seen that it actually saves life. There has been several papers published in the Neurosurgical Journal in which they have shown that if you do early tracheostomy in patients, they actually help to reduce the ICU stay in the hospital. and ventilator-associated pneumonia is completely decreased. Ventilator dependency is decreased. DVT prophylaxis is important, but don't start immediately. If you have a hemorrhage, usually start 48 to 72 hours later. Seizure prophylaxis is important. So you start any kind of anti-seizure medications that you want. ICP monitoring. So ICP monitoring is again a very important part if somebody's GCS is less than 7, because you don't know what's happening, especially in diffuse axonal injury. You have no idea how to manage their intracranial pressure, and you need some sort of a monitor to understand. You need a number, a fact. And later on, when we talk about the ICP, we will talk further about it, that, you know, how ICP monitors are placed and what is their role. But this is just a general overall guidance that I'm giving to you right now, that, you know, you should have a checklist for any kind of neuro ICU patient, and you go through the checklist. You tick, okay, I've done this, I've done this, I've done this, I've done this. And this is exactly your checklist is. So you need ICP monitoring. Sometimes you need advanced monitoring. For example, you need somebody has another chest injury. So they may need a CVP line or something like that, or an arterial line. So advanced monitoring is also required. ICP and CPP is something that you require both, so that you can manage your intracranial pressure in the medical management ways. A few other things that are also should be on your checklist is prophylactic hypothermia. The role is in this day and age is quite limited. You cannot do it for long term, but a short term prophylactic hypothermia may help to reduce the intracranial pressure a little bit. The rest we have talked about. Nutrition should also be started. Please don't forget the nutrition and NGTO on these patients, and nutrition as well as free water needs to be started. Now, the last thing that is actually left is a decompressive craniectomy. So you do a decompressive craniectomy when you have done you have marked all your check boxes that I had shown you all throughout. You have placed an ICP monitor, you have done your cerebral perfusion pressure monitoring, you have given all your medications, you have done hyperventilation, you have done everything, you have done propofol management, ICP management, normal saline, mannitol. And if it doesn't happen, then decompressive craniectomy should be your absolutely last choice. And it should happen only when your ICP is sustained 20 for several hours and is completely refractory to medical therapy. And only you would do it at that time. And why am I saying this, right? Why don't you say, well, why don't we do a decompressive craniectomy initially and get over with this whole ICP issue? The problem is that there have been several very, very important trials that have been out there, which I'm going to go through further in my lecture, which will tell you that this decompressive craniectomy does not have such great results that we theoretically expect them to have. They do increase the mortality a little bit, but the morbidity, the vegetative state, and the coma that happens to these patients is unchanged if you whether do a decompressive craniectomy or medical management. So as we go through the lecture and we go through step by step, I'll also show you those trials so you understand why decompressive craniectomy should absolutely be your last choice. So with this, I'm going to come to the neuro ICU for elective surgeries now. So we have gone through the neuro ICU management of a critically ill patient for trauma, which requires pre-hospitalization management, emergency room management that you have gone through, which is the ATLS, the primary secondary survey, and then your neurosurgical management, in which you go through the checklist that I showed you earlier, which is this, and make sure that each one of them is covered. And this is how you manage your your trauma patients in ICU. Now, for example, you have to manage an elective surgery in the ICU. So what are some of the proposed criteria for admission to ICU for elective surgeries? So preoperatively, when you see these patients, you have to make sure that what is their ASA physical status, it should be greater than 2. The Karnofsky score should be at least 70. Preoperative neurology should be at least, GCS should be at least 14. But if there's some patient who have a fluctuating neurological status, right, which happens sometimes, then that could be a criteria for admission to ICU for after elective surgery. Or there's a rapid progression of a focal deficit in some patient, and that requires an emergent surgery for some case, and then of course you require an ICU for that. Most of the elective surgery in neurosurgery can be managed in a high dependency unit and may not require intubation and ICU. But these are the few preoperative checklists that you have to go through before the surgery. Now, for example, you did not have preoperatively these kind of problems, something happens intraoperatively. And then you think during the surgery that this patient will require an ICU, okay? Now, what are those things? For example, you are doing supratentorially a vascular tumor or AVM, an aneurysm, a thalamic tumor, or an infratentorial tumor. And as a result of which, you expect that this patient may undergo diabetes insipidus after surgery. There was a prolonged temporary clipping for an aneurysm. There was intraoperative seizures. There was an awake surgery, which was greater than 6 hours. If these are the conditions that happen intraoperatively, then within the operating theater, you started thinking that, hey, this patient is going to require an ICU. And you start telling your anesthetist that, okay, this patient should go to ICU post-operatively. Now, what are the few things that can happen post-operatively? So the patient may do very well after the surgery. Intraoperatively, there's no complications. Patient goes to HDU, but in the HDU, something happens that makes you patient to bring to ICU again. And those are the few things that are like, for example, patient had developed a late ischemia, an infarct, patient has a rebleeding, patient gets severe infection, meningitis, develops status epilepticus or seizures, becomes unconscious, GCS starts deteriorating, or other things like hemodynamically, patient becomes unstable, either because of blood loss, because of acidosis, sepsis, multi-organ failure, or swelling in the upper respiratory tract. These are also few things that post-operatively demands thinking that these patients should be admitted to ICU for elective surgeries. Now, once one of these patients are in the ICU, then what are the things that you need to monitor to these patients? So the clinical surveillance is absolutely the hallmark. So no matter how much I say, it is just not enough that how much a clinical exam in neurosurgery is important. What I feel sometimes that as we are advancing in science, there is so much reliance on technology like CT scan and MRIs and sometimes ICP monitors. But remember, all of these cannot come up to your clinical surveillance of an exam, because in many LMIC countries, there is no readily ICP monitor available. There is CT scans are far away. MRI, you don't even have a concept of having an MRI. What do you do in such situations? And to save the life, one most important thing that has been shown throughout is your clinical exam. So GCS, like your level of consciousness, your pupillary reaction, your focal deficits, your cranial nerve exams. You keep on doing in the ICU every hour. So that the nurse on duty makes sure that every hour she is monitoring all that. Systemic monitoring every hour is also important, which requires ECG, your heart rate monitoring, respiratory, your oxygen, PCO2 is monitored. Blood pressure monitoring can be done by invasive monitoring, like an arterial line, temperature probe, things like that, which is your systemic clinical surveillance. Third thing is the brain-specific monitoring. So you can have an ICP monitor, whether ventricular catheter or parenchymal catheter, and through which you can monitor the CPP and do your medical management. This could be post-surgery, that could be pre-surgery, again, depending on the situation. In case of a aneurysm, you can also do your transcranial Doppler monitoring. Thermal diffuse probes are also available. Oximetry, microdialysis, jugular venous oximetry. You can do EEG, SSEP, BAER. So there is a gambit of things that you can actually do in the ICU to monitor your patients, again, depending on the criticality and the situation. Other few important things is, as I said, sometimes you need a central line, you need an arterial catheter, you need a urinary catheter, you need a gastric tube. You need these kind of labs almost once every day, sometimes twice a day even, and especially the neuro ICU patient sometimes undergoes a lot of electrolyte imbalances. They can get syndrome of inappropriate diuretic hormone release, or they may, most commonly, they get cerebral salt wasting, they can get diabetes insipidus, and as a result of which your electrolytes are completely imbalanced, and they sometimes require monitoring, more than twice, maybe 3 times a day, Q6 hours even. Imaging examination requires chest radiograph, especially in a ventilated patient, and any kind of lung procedure, for example, if you have done for a pneumothorax or any other thing, then you require also chest radiograph. A CT scan to follow up or MRI to follow up, again, depending on the situation, one decides which one is more important. So the key points for examining, evaluating, and managing a critically ill neurosurgical patient is the criteria that you need to keep in mind for postoperative admission to ICU or high dependency unit or a specialized neurosurgical ward. And again, the specialized neurosurgical ward depends from institution to institution, depending on your local availability. There are hospitals that have dedicated ICUs for neurosurgery. There are hospitals in which just a general surgical ICU may accommodate a neurosurgical patient. For ICU admission, these criteria are not they are not research proven, but they are expert suggestions. And patient care should be done in context from case to case basis and the criticality of the situation. And it is highly recommended, as I said, clinical vigilance, clinical examination in the immediate post-op period in these patients are very, very important. So if they are junior medical students, junior residents, or junior consultants out here, the one message I want to give that, when you have completed your surgical procedure, no matter what it is, just don't leave the patient even in the theater. What I've sometimes found that the anesthesia service may not be as vigilant on the blood pressure monitoring. The blood pressure may swing and may fluctuate in these patients. They may extubate the patient when the patient is not fully awake. And these are the kind of things that I have learned in my experience as being a neurosurgeon. And therefore, what I usually do is I never leave my theater, and I keep a very close eye on the blood pressure fluctuation when the patient is getting extubated, making sure that the patient is awake before it's extubated. And when he's moved to the recovery room, he's absolutely in a hemodynamically stable condition and a neurologically stable condition. And that's a message I want to give to all the junior doctors and medical students out here. Brain CT can be obtained rapidly in case you have a case of neurological deterioration to exclude intracranial complication. For example, you bring the patient to the recovery room and suddenly from the GCS 15, the patient drops down to 10, 15, and you're just worried that a hematoma may have happened on your tumor bed, or if you have done an external ventricular drain or VP shunt and you think that maybe a hematoma has expanded. So a brain CT should be done immediately. And the last thing is that the communication amongst the neurosurgeon, the neuroanesthetist, and neurointensivist is absolutely critical to optimize the preoperative management of neurosurgical patients. So again, it is a teamwork to take care of neurosurgical patients because you require somebody to take care of your ventilator settings, your ART lines, your CVP lines, how your propofol is administered or any other kind of anesthetic agents are administered. So communication of all these three helps better outcome of your patients. So this is the first part of the topic, which was the evaluation of critically ill patients in trauma and in preoperative assessment of elective surgical patients. And then how would you manage them in the neurosurgical ICU? The second part of this talk is about the management of raised ICP for trauma and hydrocephalus. So when we talk about this, what are the few things that everybody needs to know? Absolutely basics has to be on your fingertips. You need to know what are the intracranial contents, what is a Monroe-Kelly doctrine, how do you measure the ICP monitors and their waveforms, how do you calculate a cerebral perfusion pressure, what are the types of edema and what are the types of herniation syndromes, and how do you manage a raised ICP. So first we talk about the intracranial contents. So we know that the skull is a fixed wall. It's like a box with a fixed size, okay? So only fixed things can be placed in it. And in our case, there's about 80% is the brain parenchyma volume. There's about 10%, which is about 1400 ml. The blood volume consists of the 10%, which is about 150 ml. The CSF volume also consists of 10%, which is also about 150 ml. And this makes the complete contents of your cranial vault. Anything that it cannot fit anything anymore. So if anything extra comes into it, something needs to give away. So what is a Monro-Kelly doctrine? Monro-Kelly doctrine is about 200 years old. And it's amazing that even in this day and age, the first thing we taught a neurosurgical resident is what is a Monro-Kelly doctrine, and still prevails after 200 years. It says that an increase in the volume of any of the contents within the intracranial vault must be met with a decrease in the volume of another content. If it doesn't happen, then the intracranial pressure will rise, which means that your vault is a combination of your CSF, which is about 10%, your brain, which is about 80%, your blood, which is about 10%, and there is 1% other things like limbs and stuff like that. So as you can see that you have a skull vault and you have brain tissue in the first image, you have CSF and you have blood. But as you see in the second image that if there is a tumor or there is some other structure that comes into the brain tissue, then the amount of CSF and the amount of blood is reduced. And that is exactly what Monro-Kelly doctrine says, that if you're going to accommodate something in the cranial vault, something has to go down. So in case if the tumor comes through, then the CSF goes down and the blood goes down. So what happens that when you have a normal state, a normal ICP in a normal state, you have your brain, you have your CSF, and you have your blood, which is the arterial volume as well as the venous volume. Now, for example, you are entering into a compensated state. For example, there is some tumor, some lesion that have started to occupy some of the cranial vault. So the first thing will happen that the CSF will give away. So this much amount of CSF is no longer there. The CSF volume decreases, and this CSF is redistributed into the compliant paraspinal CSF spaces. Simultaneously, the venous volume, you cannot change the arterial volume, because if you change the arterial volume, then you will get hypoxia and you will get infarct. But a venous volume can be easily managed, and the venous blood is actually forced into the internal jugular vein. And as a result of which, the brain remains in a compensated state and the intracranial pressure remains normal. But if the mass, as you can see, the mass is smaller here, but in the next image, you see that the mass is much larger. And you see all the CSF has drained out, much of the venous volume is drained out, and now there's not enough space and the ICP starts to elevate and the patient comes into a decompensated state. So again, this is what I had shown about the intracranial contents and the fixed vault. This is called a pressure volume curve. So the pressure volume curve is just an extension of the Monro-Kelly doctrine. It says that, initially when you are in a compensated state, for example, in 1 or 2, the intracranial pressure is not rising, right? But as the mass increases, the intracranial volume rises, intracranial pressure also rises. Sorry about that. I'm going to go back again. Yeah. So when this happens, the intracranial pressure rises and it keeps on rising. But again, you are in a compensated state, which I will show you from your next slide, what a compensated state means. And then even a 5 cc increase in any kind of mass will actually increase the ICP in a very steep curve. So you see that the curve is pretty straight up till 3, and then it suddenly rises, right? So this rise happens in a very short period of time, and this rise happens in with a very small amount of volume, okay? So now, if this volume is so low that it can cause a sudden sharp rise, it doesn't correlate that you can remove, for example, if there is 5 ml increase, which causes the ICP to go from 10 to 20, theoretically, you would think that if you remove those 5 cc's, you will bring your ICP back to 10, but it does not happen. So a neurosurgeon needs to understand that removing the small volume will not drastically bring the CSF down, because you have passed the compensatory phase. So for now, if you reach a time where your ICP is very high, then you have to remove a larger volume to decrease the ICP down. So the key points of Monro-Kelly doctrine describe the relationship between the contents of the cranium and the intracranial pressure. And in non-pathological states, 3 components exist in equilibrium, which is the ICP, the brain tissue, the blood, and the CSF. And small volumes, I said, can be accommodated by compensatory changes in which one CSF goes down or the venous blood goes down. But when the volume becomes larger, then the compensatory mechanisms are completely exhausted. And at that time, there's a sudden sharp rise in the intracranial pressure, and which can, of course, cause potential herniation. Remember, this Monro-Kelly doctrine only applies to adult where the vault is fixed. If there's a child who have open fontanelles and open suture lines, then of course their brain can compensate much more than a fixed skull vault. So remember, this rule applies only for adults with fixed vault. So now we next go to what is a compensated state and what is cerebral blood flow and what is autoregulation. Now, these are the key concepts that everybody who is during neuro ICU must understand. So a cerebral blood flow, by our blood in the brain autoregulates itself over a wide range of mean arterial pressure. And that happens because there is flexibility in the vessels, right? The vessels can constrict and the vessels can dilate depending on the mean arterial pressure, and autoregulates the cerebral blood flow. And why that happens? Because this is a defense mechanism created by God, that this ensures that automatically either the vessels are going to dilate or constrict so that the oxygen and the metabolic substrates, the neurons, remain unaltered, right? And when the ICP becomes greater than 20, then it has been shown that in both adults and peds, it is associated with increase in the morbidity and mortality. And the reason is because when the ICP is elevated, then the cerebral perfusion pressure is decreased. And when the cerebral perfusion pressure is decreased, then compensatory mechanism is completely gone, and a result of which morbidity can occur. Now, there's a minimum cerebral perfusion pressure requirement. For adults is usually the 70 millimeters of mercury, and for children is about 60 millimeters of mercury. So this is one slide that actually helps you to understand the autoregulation. So you see that between 50 and 150 mercury of blood pressure, there is no rise in the ICP, right? And as you can see above, the circles are showing that the vessels are autoregulating themselves either by constricting or by enlarging. So if you remain between 50 and 150, your vessels will automatically autoregulate itself so that the oxygen and the important nutrients continues to be supplied to your neurons and to your brains, and nothing will happen. You will not know. However, decompensation starts to happen when you pass below this number, right? So if you go beyond 150, then there's a forced dilatation of the vessels, and a result of which vasogenic edema will occur. Or if you go on the lower side, then the artery will collapse and you will have ischemia. So the take-home message from this slide is that between 50 to 150 is your ideal number in which the autoregulation happens, and you should manage your patient, the mean arterial pressure of within this range and not below or not above. So after understanding what is cerebral perfusion pressure, what is a intracranial pressure, cerebral perfusion pressure, and cerebral blood flow, and how the cerebral vessels auto-compensates on its own, the next point that I want to come to is about ICP monitors and waveforms. So, for example, if you are in a situation that a patient has clinical sign and symptoms of raised ICP, you are worried that the cerebral perfusion pressure is decreased. And as a result of which, you are afraid that this ICP may be greater than 20, and this may cause patient morbidity or mortality. Then the first thing we do is think about intracranial monitors. The intracranial monitors can be used in trauma situations, in elective surgeries, in hydrocephalus. It is one of the most common and the first thing you learn as a neurosurgical resident. So there are two types. Number one is, of course, the intraventricular monitoring, and second is the intraparenchymal monitoring, and both are very commonly used throughout the world. In LMIC, intraparenchymal monitoring is a little bit restricted only to very few centers because of its extreme cost. But intraventricular monitoring is absolutely available worldwide. What are the advantages of intraventricular monitoring is that it is simple management. You do a CSF drain. And the disadvantage is that there's a very high risk, about 20% risk of infection and hemorrhage. With intraparenchymal monitor, the advantage is ease of placement, lower risk of infection and hemorrhage. But the biggest disadvantage is, remember, it's an electrode and a very thin one. So what happens that this electrode, if it is moved within a couple of days, then it loses its accuracy and it cannot be floated back again. It has to be a complete new procedure that you have to do. So here you can, as you can see, that if you place an intraventricular monitoring, usually the one-way stopcock is usually at your external auditory meatus, which is your zero value. And then you can go either centimeters of water or mercury of Hg above. Most common neurosurgical ICU usually follows the centimeter of water. So as you know, the normal ICP ranges anywhere from 7 to 15. So you can, depending on whether if you want to keep your chamber, your drip chamber at 5, 10, or 15 centimeters of water, it will drain the CSF accordingly. If it's 15, of course, whenever the ICP goes about 15, it will drain. Sorry. And if it is 10, which is usually when somebody has hydrocephalus or infection or intraventricular hematoma and you want to drain more blood or more infection out, then you usually keep it 5 or 10 centimeters of water. The few things that are very important here is that the one-way stopcock should be at the external auditory meatus. The nurses must know where the drip chamber is and how it is set. Now, after this, I'm going to show you a video on how do you insert an external ventricular drain and how do you insert an intraparenchymal monitor drain. This is just few general steps that I'm showing, in which first you have to make a tiny hole, a small twist drill hole. And after the twist drill, there is a device that you secure to the bone. And then in C, you float the monitor. And once that monitor, which is an electrode that goes into the brain, into the parenchyma, then you hook it up to the monitor, and that shows you the exact number. So this is a cartoonic representation of when the intraparenchymal monitor goes into your brain. It only has to be this depth that will give you a good idea. And this is a Codman monitor, and it usually reads the ICP like this. So it's very easy. You get a number. Now you have a better idea how to manage it. If the ICP is rising, you can start your medical management. You can increase the mannitol. You can increase the 3% normal saline. You can hyperventilate the patient, elevate the patient 30 degrees, increase the propofol, pentobarb coma. Again, entire medical management can be done if you have a number which actually helps you tell that what is your ICP. The problem in this situation is because you actually have lost a neurosurgical exam at this point in time, because the patient's GCS is usually less than 7 and the patient is intubated and on propofol. So that helps you to give you a better guide of what the intracranial pressure is going to be like. Before going to the video, the one other thing that you must learn as a part of the neuro ICU curriculum is what is an intracranial pressure waveform. Okay, so this is a normal waveform. It has a P1 wave, a P2 wave, and a P3 wave. Normally, the P1 wave is greater than P2 and P3. And the P1 is the representation of your arterial pulse. Okay, the P2 is a presents a tidal wave, which is a tissue compliance. For example, remember when you have increased blood, the vessel will compensate, by decreasing the caliber, which gives you the tidal wave, and third is your dicrotic notch, which becomes normalized. Now, this is a normal situation. In an abnormal situation, you can see that the P1 is lower than P2, which means that the arterial pulsation is happening, but the compensatory mechanism is much higher. And this actually just tells you that the ICP is very high and it is becoming a non-compliant kind of a situation. Because if the patient is still in the compensatory phase, the one that we talked about, the P1 will still be greater than P2, right? But when the P1 becomes less than P2, then it means that the ICP is rising. The brain is unable to comply with the amount of compensatory mechanism through the vessels is not working. And it is a very, very sensitive predictor. And these ICP waves, you can actually see on the monitor when you hook up your external ventricular drain or your intraparenchymal drain to your simple neurosurgical ICU monitor. So here I'm going to stop sharing my screen because the video that I've actually choose is actually on my desktop. It is actually, I pulled it out from YouTube because there were such good YouTube videos that I could find that I decided why do I have to make my own? Because it just gives you a very clear idea of how the procedure can be done. Okay, so I'm going to decrease this down. Hold on. To stop the share. Yeah. Oops. Sorry about that. I'm just trying to reach my screen. End the show. Yeah. So this is the video. John, can you guys see my desktop and the video?
Yeah, I can see the desktop, but it's a small screen and the video is not playing yet.
Okay, let's see.
You can just make a presentation and share it.
Can you see the video playing now?
We can see the beginning of the video.
Okay, great. So here there is the procedure of placement of ventricular drain.
I'm sorry to interrupt. It's not playing.
It's not
playing. The video is not playing yet.
Okay.
Madam, instead of the PowerPoint, I think you have to go and just minimize the PowerPoint and go and share the screen video. So since the screen that we are seeing is the PowerPoint.
That's it.
Oh, so what do I do? Stop the video?
Madam, if you will have to share it again. Just stop sharing this and share the video again. Yeah, exactly, ma'am.
Just share put the screen. Video on.
Yeah, and the video one because
don't put the PowerPoint on.
Yeah, exactly.
The video.
That's the little catch over there.
So the only problem is I have to share the screen because it's on my desktop, right?
Oh,
exactly. Okay. Just minimize the PowerPoint and just proceed with the screen.
Okay, let's try this one. Now, can you see?
Yeah, yes. Exactly.
Yes,
great.
That's it.
Okay, okay.
Thank you.
Great.
Play that video. Okay.
Yeah. So this is a video that is very readily available in any YouTube that you guys can go and check it out. There are multiple videos. I picked it up because it exactly shows how can you put an external ventricular drain you have to choose your coca point, which is about 11 centimeter from your nasion back posteriorly and 3 centimeter lateral. Usually I do on the right side, make a small incision. Then you actually cauterize the area so that there's any kind of stop the bleeding, then you remove the periosteum, make a burr hole at this site, and remove the bone. And the shards of some bone, which is the inner table of the bone, which sometimes are left after the drilling. Bone wax the edges so that stops bleeding back, especially when you are doing your external ventricular drain. Next step is you cauterize your dura, because sometimes the dura can have big vessels on it. I have got few heart attacks in my life after opening the dura, and there's a whole gush of blood coming towards me, but usually it's controllable completely. You just need to have a diathermy in hand. And you cauterize the dural edges, and you perform a little corticotomy with your dural forceps. And then you take the external ventricular drain. And again, if you're doing frontal, okay, there are two landmarks, which is your nasion or external occipital protuberance, usually 90-degree perpendicular to the head. You go up till 5 centimeters, and usually you should be able to hit the frontal horns of the lateral ventricle. And as soon as you feel a pop, you take out the inner stylet, and you would see the CSF coming through. In this case, of course, it's bloody CSF, likely intraventricular hemorrhage in this patient. And then you have to remove it from the side using the trocar. Make sure that you're holding the external ventricular drain at your burr hole side, and then taking it out with the trocar from a little edge. And then place the cap at the edge. Don't forget to secure it with your silk suture. And if you like, you can put a little bit of fibrillar or a little bit of gel foam at the burr hole side. Do your hemostasis. And then closure. You can do 2-layer closures, one with your 2O vicryl in subcutaneous inverted sutures. And then you can follow it up with either a proline or an ethanol on the top, or staples. Again, your choice, the way you are comfortable doing the closure. Once that's done, you open to make sure that your external ventricular drain is still working. And then you also tie the drain to the side where you exit it out. Make a U-turn so that, and put a lot of upside or tegaderm on it so that it doesn't remove. So this is how you would do an external ventricular drain. My next video is about how to do an intraparenchymal drain. So starting it right now, I am going to mute it so that I can actually talk myself. So this is a video. It's an excellent video from New England Journal of Medicine. Please, if you find it on the YouTube, you can just see it multiple times and learn how to do an intraparenchymal monitor before you attempt to do it yourself in the hospital. And again, I said, it's quite simple, quite straightforward. It has few complications like hemorrhage or ventriculitis, etc., etc. But the biggest problem is that the electrode gets displaced very easily, and the ICP number that you get may be erroneous. So here they are showing a CT scan in which patient has severe traumatic brain injury. With an abnormal CT scan, you can see there's some diffuse axonal injury, there is some contusions that is happening in this patient. And the contraindications for this is patient has coagulopathy. The platelet count has to be greater than 100, and the ICP should be INR should be greater than 1.3 to 1.5. The equipment that you're going to need for the intracranial pressure monitoring is the piezoelectric strain gauze, the fiber optic monitor, and the pneumatic monitor. And the next image will show you how you're going to start doing the procedure. You're going to need some non-sterile glove, of course, and razor, marker pen, just normal things that you require to do even in intraventricular monitoring. Now, these procedures can be easily done bedside. You don't have to go to operating theater to do it. It could be done in the emergency room. It could be done in the ICU. It can be done in the HDU. The only thing that is more important is that you need some help, and a nurse is completely, perfectly capable of helping you out. So you don't need anybody else to do it. And you can do it. This is the ICP monitoring kit that you can see. It has a small disposable drill that you can use, because remember, this is not a burr hole drill, but it's a twist drill, which is much smaller than a burr hole drill. So starting here, you clean the head. Again, where do you want to put the intraparenchymal monitor? I would just use the Cocos point, okay? 11 and 3 is usually my landmark. Use the Coca point to do either intraventricular monitoring or intraparenchymal monitoring. You make a tiny little incision, you wash your hands, again, it has to be done in sterile condition, because now look, the twist drill is so much thinner than your burr hole drill, right? Because the hole is really, really tiny here. So the first thing you do is actually you set up everything. Usually this is how I was taught to do, is that first you open the kit, you set up everything, you set up your disposable drill, and once everything is ready, then the procedure can actually be done in 5 minutes. And then how much deeper you want to go, you just do that. So look at the tiny incision, okay? You clean it up. Give a little bit of local. Make a tiny little incision with an 11 blade. Use your twist drill to make a hole. And remember, this is not the regular burr hole drill that you have in the operating theater. So it will not stop automatically the way it does when it senses that the pressure is released. Here you have to be very, very careful. The moment you feel that your bone is give away, you have to stop. Otherwise, you are going to go into the brain. Once that is done, then this is a screw that you put it on. And through the screw, what you do is this instrument went in there to puncture the dura. And now this is your microelectrode that you will insert through that screw. First, you connect it and you zero the monitor. So you connect it, you attach it, and you zero it. And once it's zeroed, then you enter this tiny electrode into the brain parenchyma to the depth of about 15 millimeters. And when that is done, you make sure that you make sure that it is giving you the accurate ICP reading. You cover it with a betadine soaked gauze, and then that ends. The complication is usually, I'm going to again start sharing my screen. So I'm going to now share my presentation screen back again.
Yes.
Okay. Can you see it?
Not yet.
Okay, let me try it again.
Okay.
It is not somehow sharing it. Okay, what am I doing wrong here, John?
No, it's not sharing. I don't know why.
So I've stopped sharing it. Now you can see me, right?
Now we can see you, right?
So
just maximize
now,
your, madam, just maximize your PowerPoint presentation. I think it is minimized in your screen. Just maximize it and then share again.
okay.
Just open your Zoom window over your PowerPoint presentation. So it will read that it is on the priority list of things.
No, I keep sharing this screen again and again. Okay, let me just share it back again. See, this is what I wanted to share again, right? Or shall I share this screen? Let me share this screen back again.
Yeah.
Share the screen. Yeah, let me share it. Yeah. And if I exit this full screen,
Yeah, you may be.
and here I can start. I don't know what's happening here. I'm making some mistake. Okay, what if I close this? And it's right here.
You might have to get off all your screens other than Zoom. You may have a lot of conflicting programs. And then come back to screen share after you get rid of all the other screens.
Sure. Can you see my my desktop right now?
Yeah, it looks like it's trying to start, but it's not completing. Can you double click your mouse? And you're off everything besides Zoom, correct?
Yeah.
And the screen. Is it finding it on your desktop? Is it?
Yeah, it's right here. See, it's right here.
You can see it, huh? But we can't see it.
Sorry about that.
No, ma'am, that happens so frequently. We had a lot of problems last time we were here. People could not even share their screen at the first time.
Yeah, there was a problem with Zoom.
Yeah. Last time we had so many things going on with the Zoom.
Yeah, it was working fine before. It was working fine.
Okay, I'm actually going to close this. Okay, let's see, because it's saying activation failed.
Maybe if you get off Zoom totally and just come back in.
Sure, let me do that. Yeah, let me do that. Let me just get out and come back again. Okay.
We'll have a digital coffee break.
Oh, okay, great. Just give me 2 seconds. I'll be back. Dr. Tariq, hi, how are you?
I'm good.
I'm going to just, good. Yeah. I'm just going to leave this meeting and I'm going to come back again. Okay, great. So.
Thank you, sir. Welcome, sir.
Yeah, thank you. Thank you. Good to see you all.
Thank you
Thank
so
you.
much, sir. It's a matter of huge honor and pleasure for us to have you here today to deliver your wonderful lecture.
Thank you. It's an honor to
Hi,
be
Professor
here.
Borba. Hi, Professor Borba.
Good morning. Good morning.
Good
Good
morning,
morning, Professor
Louis.
Tarek.
morning.
How
Hi,
are you?
Louis. How are you? I'm good. Thank you.
Thank you for coming. Thank you very much.
Welcome.
Yeah, let me take this opportunity to talk about the webcast we have. I was telling Louis about it tomorrow morning at 8 o'clock Eastern time with Yuha is presenting in front of the Chinese Neurosurgical Journal crew. We hope to have a lot of people, important educators from neurosurgery there to show the Chinese we really want to collaborate with them. Of course, collaborating at the very basis of neurosurgery, evidence base in the journal. It's an English speaking journal. They want to bring attention to the journal, to the English world, that they have a English speaking journal for China in China, for the Chinese Neurosurgical Journal. What do you think? What do you think of that, Louis?
Yeah, I think it would be great. See, in China, you have the largest number of neurosurgeons in the world. In the
Yeah,
community, yeah, I think it would be great. It would be great.
yeah. I think
And
they
you
have
have
more English speaking neurosurgeons than anywhere in the world.
Yeah, it's good. It's good.
So we have the yes.
Okay, we're still waiting for. Let's see here.
So we have the conference of anatomy by Professor Polikadri today. I think of just after our own conference.
Anila,
What's happened with representation? She couldn't
I
share.
think
Anila,
she
she's
didn't
not
get
back
back
in
in.
yet. I hope
Can
she's
I-
not having computer
can-
problems.
Can I
Maybe-
try and share my screen to see if it works?
Please,
Yes, sir.
please.
Please do,
Nor,
sir. Please,
what do you
sir.
want to do, Nor?
Yes, sir. Please, sir.
Yeah.
Great, sir. We can see it. If you just yes.
Yeah.
Great, sir. So do you have any videos in it?
Not really. It's a tiny video. I'm sure it will work.
Yeah, exactly.
If it doesn't matter really. Okay,
Sir, I
let me
think
get
it's
let
going
me
to work.
stop. Yeah. Yeah. Okay.
Thanks a lot, sir.
Yeah, thank you.
Maybe we could continue with Professor Ken. Huh?
Yeah, maybe. Yes, sir. I think so.
Yep. Yeah.
You know, it's a
want
great
me?
pleasure to us to have Professor Tarek Khan here. Professor from Pakistan, he's Dean of Northwest School of Medicine. You take your time with us, see, for the medical students, for young residents from around the world, this is being recorded. I know a lot of people from 5 continents will watch and listen your presentation. Thank you very much, sir, to take our time. Thank you.
Thank you, Louis. Thank you, Dr. Noor. And thank you, John, for inviting me to give this talk. So Anila is back online. Do you want me to continue, or you want her to
Yeah.
do her thing?
She's back?
Yeah, she's back.
Yes, Dr. Hi, Dr. Borba. How are you? I'm Dr. Neela. So
Yeah.
how are you? I have only one last part left of my presentation, which is about mergulous cerebral edema. So if you don't mind, I would just like to finish it.
Yeah. Professor Tarek, decide.
Yeah, that's fine. No. Ladies first.
Can I go ahead? Okay.
Okay, great.
Go ahead, please.
Thank you. So I'm going to share my screen. Sorry about this confusion. I'm going to go back again. We have talked about evaluating critically ill patient in trauma and elective neurosurgical. We talked about ICP, ICV waveforms, Monroe-Cali doctrine. We have talked about ICP, CPP management, cerebral blood flow, autoregulation. And the last we were talking about was the normal and the abnormal ICP waveform. And let me just do the screen. Yeah, so slideshow. So this is what we talked about. We saw the videos on both how to place an external ventricular drain and how to do an intraparenchymal drain. Both should be readily available in most of the countries worldwide. And after that, I just want to touch base with the different type of herniations that are that you would consider. These are the most common herniation syndromes that you would see. I'm not going to go into details over here because this is not the topic that I'm talking about today. But these are the 4 or 5 herniations: the subfalcine, transtentorial, transcalvarial, uncal, upward and downward cerebellar herniation that every junior consultant, medical student, or a resident must know and must know how to manage them. The type of edema that we want to talk about is vasogenic, interstitial, and cytotoxic. And vasogenic edema, in which there is increased permeability of the brain due to abscess, most commonly we see in tumors. Interstitial usually happens when there is decreased CSF absorption, and cytotoxic edema is the one which happens when there is neuronal swelling due to the loss of ATPase sodium pump, as a result of which diffuse axonal injury, and usually the most irreversible type of edema. So because of the time limit, I'm going to go really fast over here. And we have gone through the Monroe-Kelly doctrine, and we have talked about the hyperosmolar therapy, how to do hyperventilation. And the last thing, as I said, is decompression craniectomy. And one of the cases when you can do a decompression craniectomy is when you have a large middle cerebral stroke, or a stroke that can happen as an iatrogenic injury. When you do the decompressive craniectomy, make sure it is the last resort. And the other thing, it has to be large. At least should be 12 centimeter in size from front to back to give. If you are opening the cranial vault, let's open the vault big. There's no point doing a smaller cranial vault operation. And these are the bad H's that you have to keep in mind, which is the hypotension, hypoxia, hyponatremia, hyperglycemia, hypervolemia, hyperthermia, and hypermetabolism. Now, these are the 3 important trials that I wanted to talk to you about. And the reason is because why decompressive craniectomy is not the greatest and the best and the earliest option, because the 3 trials that were done, the rescue ICP, the DECRA, and the STITCH trial, which was about, number 1, intracerebral hematoma, diffuse axonal injury, or intracranial hypertension, have seen that doing a decompressive craniectomy may decrease your mortality, but the morbidity, which is in the form of coma or vegetative state, is usually pretty long lasting. That brings me to my last topic, which is the malignant cerebral edema. And for that, I'm going to do a case very quickly of an 84-year-old who presented to me with hemifacial weakness and left-sided weakness with gait imbalance. He was quite old, and I was questioning whether he should be operated or not, but he was going down so fast, and he was a doctor himself. His son was a doctor, and we decided that we will do an operation on him. Now, let me show you his exam. He was drowsy. He had left-sided weakness, pronated drift, wheelchair bound. And when we did an MRI, there was this large lesion, as you can see over here. It was an in-plaque meningioma. This in-plaque meningioma was recruiting the insular, the M3, and the M4 branches of the middle cerebral artery. And to remove this, there was, of course, the family had to be notified earlier that he may get a big infarction after that. With this consent, we went for the surgery. It came back to be a typical meningioma, WHO grade 2, with a high nuclear to cytoplasmic ratio. The patient got intubated, was okay, and then he self-extubated himself. And we said, okay, he's fine, he's following commands. He self-extubated himself. But after a little while later, went about, his GCS deteriorated. Now, remember, we talked about the secondary injury that happens after the primary. This was what was setting in: inflammation, cytokine markers, oxygen-free radicals. And we got a CT head, which showed that he had cerebral edema. And can you see the video playing here, John, Maria?
Yes.
Yes. So as you can see that this is the...
Yes, ma'am.
Yeah. So as you can see that the tumor is removed, but there is extensive swelling and there is midline shift. And at that time, we decided that a decompressive craniectomy needs to be done. And of course, when we do it, remember, you do it big, you remove the box full, 12 centimeters was done. And also steroids and mannitol was given. And then this is the postoperative scan that I'm going to show you very quickly. Now you see this patient has developed some ischemia, right, on the side, and as a result of which he had the injury. And when the CT head was done, it showed infarction in the M3 insular branches, but not the infarction of main trunk of the MCO. And he had a tracheostomy done. He regained consciousness, and then he was sent home to the family care. So what are the few important things that you learn from these basic management? Number one is that learning surgery is important, but also learning medical management of this critically ill patient is absolutely important. You will learn to do decompressive craniectomies very easily, because that will be doing day in, day out. But when not to do a decompressive craniectomy and when to medically manage the patient is the most important thing you need to learn as a neurosurgical resident. Second point I want to make, that please own your patient, because when you have a neurosurgical patient, there's neurointensivist, neuroanesthetist, and don't rely on them to make your own decision, but be in a team worker. Give your input, give your advice, give your direction. Remember, it's your patient in the end. Always keep the family in the loop. When complicated cases happens, the family communication should never be broken down. In the LMIC countries, sometimes you have to do a makeshift EVD by using a feeding catheter, and that also works. You just put the catheter and drain the CSF 5 to 10 ml per hour. That can also work. And in the last, my point is, for a neurosurgical virtual workshop, that neurosurgical assessment is the key to monitor the progress. Thank you so much. And I've taken a little bit more time, and sorry about the video not playing, and I'm going to give it to Dr. Tariq Khan now.
Thank you so much, madam. Thank you so much, madam, for the amazing workshop.
I have stopped sharing the screen. So Dr.
Okay. Maybe you can start, Professor, please.
Yeah. So thank you once again, and hello, everybody. Thank you for inviting me for this very important meeting. So I'm going to talk about cranial and spinal basal injuries, something which I feel is very important. As you can see that it is becoming very common in the Western countries as well, and United States also especially. You can see these slides moving, yes?
Yes.
So the cranial firearm and blast injuries carry a very high mortality and morbidity, as we all know. There are different types of injuries. There's low velocity injuries, high velocity injuries, then there are specifically blast injuries and others which I'll mention in a little while. So the low velocity are handguns, shotguns, air guns. Handguns have got rifling and grooves in the barrel to give a spin, and the muzzle velocity is low, 750 to 1400 feet per second, and also the kinetic energy is low. The shotguns are dangerous because of their multiple pellet effects. And the others which I was talking about was spent bullets, which was a very interesting phenomena, sad phenomena, which we used to see a lot when I came back to Pakistan from Belfast in the early 90s. People used to fire in the air in weddings and stuff, and the bullet would come down with gravity and hit people, and many people would die from that. And then, of course, you know about the air guns, which are propelled by air. Shotguns are smooth bore, and they fire multiple pellets down the barrel. and the velocity is less than 1400 feet per second. So the high velocity have again rifled barrels, but the muzzle velocity is greater than 2200 feet per second with a high kinetic energy. And the important thing is the yawing effect, which is produced by these bullets. And then because of the yawing effect, there's a cavitation effect. And you can see the yawing effect where the bullet is going up and down in the path. And then the cavitation effect. So this is just a thing from the Red Cross where the wound channel of an AK-47 bullet is being used as an example. And depends on the distance which they're traveling, you can develop a temporary cavity of 25 times more than that of a bullet, and then go back into a straight channel. So the cavitation, the yawing effect leading to a cavitation effect is very important in a high velocity bullet. The incidence is 12% for the head and neck. In the military, the use of protective head and torso armor tends to modify these figures, but this is not the case for unprotected civilians and irregular combatants. In the skull, 80 to 90% is the frontal, temporal, and parietal regions, and occipital and posterior fossa are less. Although there is more vault offering the surface area, but these patients are more likely to survive. You would see very few patients coming in with posterior fossa and base of skull injuries because they would usually die on the spot. So the factors determining the extent of injury is related to the nature of the projectile and the point of entry and angle. So the low velocity is low kinetic energy with minimal shock waves, and they enter through the weak points of entry skull like the supraorbital region or the temporal region. The high velocity are high kinetic energy and they create shock waves. And the pathophysiology is due to the primary injury, which could be the soft tissue injury only, bone fractures, which could lead to maybe even gutter wounds if it's a tangential injury. And then the cerebral injury, arterial injury, venous sinus injury, and air sinuses injury. And the secondary is brain edema, hematomas, and hydrocephalus, and later on, of course, infections as well. There can be coup and counter coup injuries, there can be shock waves, and then there is temporary cavity formation, as I showed you early. If you can see this, the way the bullet is traversing in this particular area, it is coup, counter coup injury to the brain on both sides. Blasts can create shock waves, temporary vacuum effect, stretching, deformation due to further effect, and penetrating missiles. So the nearer you are to the blast, the worse the outcome. The nearer you are, you would get the heat, the overpressure, and then if you are further away, the impact, and even further away as increasing distance fragmentation. You know that the suicide bombers, the suicide vests which they wear, they are filled with ball bearings, and when they detonate, these ball bearings move at great distances, and people are injured or even killed at that. We used to see a lot of those. Thank God we are not seeing very much now here anymore. Management, of course, depends on the ABCD, the primary survey, the wound inspection, very important, the GCS, signs of raised ICP, lateralizing signs, pupils, and hemiparesis. Of course, you take the history and complete examination, labs, blood group, cross match, cervical and rest of spine, abdomen, chest, and limbs. Airway is very important, and then depends on what, if the airway is not good, you can use a simple airway or a laryngeal mask or endotracheal intubation. Sometimes you might have to do even a tracheostomy. You have to look at the respiration rate, color of nail and skin. You may need oxygen if required to improve the brain oxygen perfusion. We have to make sure that you're maintaining a good cerebral perfusion pressure. You can give crystalloid, ringers, saline, even 3% saline, colloids, avoid dextrose. If the pressure is falling and there doesn't seem to be any big scalp area bleeding, then you need to check for other injuries. That is very important. And of course, expose the whole body, check for any other injuries, past illnesses, and if you have time, of course, very important, drugs, etc. So it's obviously very important to keep the ICP normal and the usual brain trauma foundation guidelines, head at 30 degrees and oxygenation. Mannitol in boluses or 3% saline. Sometimes you may understand that because of the firearm injury going through and through, the patient might have already decompressed themselves and you may not need these sort of medications. Of course, you need to make sure that the ICP remains low and the cerebral perfusion is good, airway oxygenation, and then important that you reassess the glaucoma score after resuscitation, because if somebody has been in shock or hypoxic, once you improve that, the GCS might improve in that. Imaging, plain X-rays can play a big role also. CT scan, brain, and very important to do bony windows and 3D imaging. CT angio may be required if you see that there's a vascular injury. Antibiotics, there is a high incidence of infection due to entry of foreign bodies, hair, bone fragments, clothing, metal, and whatnot, dirt, etc. And in the pre-antibiotic era, in military injuries, more than 60% was the mortality. Now is 4 to 11% in civil, the incidence of infections. Staph aureus was seen to be the most common organism. So broad spectrum antibiotics, cephalosporins, third generation with metronidazole. And of course, very important to give an anti-tetanus dose. And this is the paper which suggests also the same thing, important to give antibiotics and broad spectrum therapy. Seizures, these are more common than in closed TBI. And the question is whether to treat with anticonvulsants or wait. And you can see that there is a high risk, 30 to 50% of patients suffering may develop seizures, and up to 10% may develop early, some may develop very late. I personally put them on antibiotics for at least 3 months. I think it's important, especially in our setting in the lower income countries, where if during the patient being in the ward or in the ICU, and if it gets a seizure and is not noticed, the patient can deteriorate rapidly. So it's better to have prophylactic anticonvulsants. So the definitive treatment is craniotomy, removal of devitalized tissue, removal of accessible bone and bullet fragments. I think that is a point very important, that you should not go fishing and looking for the bullet fragments because you can cause more damage. So whatever is accessible, you need to remove going in the track of the bullet. And copious irrigation with saline. I think that is the key to it, that you need to continuously wash with saline, and you can use hydrogen peroxide, you can use antibiotics in saline. So I think that's one of the most important parts in that. That's just, you can see a craniotomy around the defect. So you go around the defect and you open a flap and remove the tissues. And hemostasis, dural closure, you can use pericranium, galea, fascia lata, and if you have the luxury, you can use artificial dura. I think it's important to close the dura because CSF leak can create a big problem and can lead to infections and further complications. Post-operatively, careful observation, airway, very important, humidified oxygen, urinary catheter, physiotherapy, DVT care is very important, nutrition. So DVT care initially can be given by physical means, by stockings, etc. And after 24 hours, you can start some low dose heparin. If there is a big hematoma, you should wait for 72 hours to do that. And nutrition is very, very important, should be planned initially right from the beginning. Rehab, unfortunately most neglected in lower and middle income countries, very few rehab centers. So one way is to train the family members to do the rehab at home. Outcome can be misleading because of the post-traumatic syndromes, social problems, mood swings, headaches. So you need a psychologist and psychiatrist care as well. I just want to give you a little collection of patients which we had from northern Pakistan and from Afghanistan, because we get a lot of patients from Afghanistan. And you know that our passion is that we use guns in weddings and celebrations. The children learn to use guns when they're very small. And we settle our disputes, unfortunately, using guns. We have a total of 94 patients in the past 6 years, which we were able to collect. Some may have been lost as well. So most of them were young people, of course. And this was the arrival blood pressure, and most of them had a normal blood pressure and with a normal SpO2. I must add here that because of the long distances, patients traveling from further afar with poor roads, especially from Afghanistan. So the patients arriving, maybe the patients who were the ones who were going to survive the injury. So majority had bilaterally reactive pupils. The CT findings showed foreign bodies and contusions, hematomas, herniations, and ischemia. And in the majority, we did interventions, and then interventions were craniotomies, decompressive craniectomies, or just simply debridement of the wounds. Most of the patients were on ventilation between 5 to 10 days, and the duration as usual was the same. Length of stay for most of them again was 5 to 10 days. And the final outcome was 11 patients died, 47 were satisfactory, 36 had poor outcome. These are just some patients who had firearm injuries. This looked like a blast injury. So I just moved to the spinal missile injuries. The incidence has increased to 13 to 17% of traumatic spine injuries, and the management still remains controversial. Basically, they're saying that the incidence of gunshot wounds to spine on civilians has increased alarmingly and accounting for 13 to 17%, placing them in third place among the most frequent mechanisms. However, the management of these injuries is still controversial. At present, there is little information on the management of these lesions, conservative treatment being recommended in most publications. Based on the current literature, we propose a procedural protocol aimed at improving the quickness of management as well as the prognosis of the patient. For this purpose, once the patient is hemodynamically stabilized, the following should be assessed: stability, compressive extrusion, accommodation not in discal space, and contact with CSF. So basically, in assessment, you look at the stability of the spine to see whether there's any compression, whether there's any accommodation in discal space, or there's any contact with CSF. Again, ABCD, antibiotic with anti-tetanus, wound care, other injuries, and questionable points are whether to use steroids or whether to operate or not. And antibiotics, again, the recommendation is broad spectrum and possibly cephalosporins with metronidazole and anti-tetanus. So until recently, the use of steroids was undetermined, but there have been some studies, and today it is said that this use of steroids should not be considered because they can increase the rate of complications, especially related to infections. So steroids are out. Surgery should be looked at if there's a bullet in the spinal canal, CSF leak, spinal instability, or important gradual deterioration. And in this paper, again, it says that Surgery for spinal cord injuries resulting from low velocity gunshot wounds is reserved for patients with progressive neurological deterioration, persistent CSF fistulas, and sometimes for incomplete spinal cord injuries. Surgery may also be indicated to relieve active neural compression from a bullet, bone, disc, or a hematoma within the spinal canal. Spinal instability rarely results from a civilian gunshot wound. Cardiac injuries from low velocity have a better overall outcome. But if you have a bullet injury from a high velocity bullet, you can develop an unstable spine, and you have to look at that. So that is very important to see whether this is a low velocity or high velocity bullet. And so in this, there is concluded surgical treatment is associated with higher complication rate than conservative treatment. Therefore, the surgeon must know the treatment limitations and recognize patients who would truly benefit from surgery. And the factors depend on whether it's a low velocity or high velocity, depending on the trajectory and the level of injury. I just give you a few cases, 42 cases. Again, majority were less than 35. Majority were male, and majority were close range, and majority were low velocity, but a big number of high velocity was there as well, and 16% were blast injuries. And majority were thoracic level in our number of patients, and that was the TLX score. So you know the TLX is regarding the morphology, integrity of the posterior longitudinal column and neurological status. But this paper says that TLX score is very difficult to apply to gunshot wounds, and the Dennis system provided no prognostic information despite a relative ease of use. It is their opinion that a new classification system needs to be designed to specifically include the injury patterns seen from a gunshot wound. Also, there was little evidence that abstaining from a surgical treatment would cause any significant short or long-term problems for patients. Involvement of the posterior column correlated with neurological involvement, but does not implicate the need for surgery or debridement. You all may know the Dennis classification of spinal trauma. So intervention was in minority, majority were treated conservatively, and the intervention was spinal fixation, decompression, and debridement of the wounds. Complications, ventilator dependence was seen to be high, wound infection, sepsis, pulmonary embolism, meningitis, bed sores, of course, all complications were there in that. And the mortality was 15.6%. And the mortality was more in the cervical spine. These were the patients who were mostly dependent on ventilation, and these were the ones who had a high mortality in that. The conclusion is that spinal menisci injuries are more in young males. Dorsal spine is most commonly involved. Ventilator dependence due to respiratory failure is commonest in cervical region trauma. Important to know which surgery should be done, and use of steroids is not helpful. In fact, it's just contraindicated. This is my favorite slide. I keep on showing that everywhere. I think that is very important. Prevention is the best, really, and prevention is better than cure. Thank you very much. I also would like to say that I would like to invite all of you to the first WFNS International Global Surgery Conference. It's organized by the Global Neurosurgery Committee, which is going to be held in Peshawar from 10th to 12th March 2023. Thank you very much. Just trying to.
Thank you so much, sir, for the lecture.
Thank you.
Thank you, Professor Tarek. Thank you. I really appreciate it. Nowadays, this world so crazy. See, this topic is extremely important to us to understand this terrible situation that maybe in the future you can do better. God pray to all the country. Today in in the world. We have 25 countries in war. And not this real war, but the civil gunshot is having more and more and more a days. In Brazil, the situation is an endemic. In some areas in Brazil, you have areas that you cannot go in. See, it's crazy, it's crazy. The civilization is going to a place that we don't know where will be the future. Thank you very much, Professor. I really appreciate it. Dr. Rubiano is here. Andres. Hola.
Hi, Andres. Hi, Andres.
Thank you very much, Andres. I know that in Colombia now it's 6:30 in the morning. Thank you. Thank you very much. I really appreciate it. Professor Andres Rubiano is the co-chairman and chairman of the World Federation and Trauma Committee. He took the position after Professor Tarek. It's a great pleasure to have you here with us. This meeting is for young people, see, for young residents, for medical students, for people that really is starting neurosurgery. It's a great pleasure to have you here. Please, Andres, go ahead, please.
Okay, thank you so much, Professor Borba. Thank you for the invitation and also to the organizers. I'm sorry that my voice is a little bit not working well today, but hopefully you can hear very good. Okay. Okay, so let me share the screen. Okay, so this talk will be focused on damage control principles in neurotrauma care. And we are gonna speak a little bit about the approach based on resources availability. There is no conflict of interest. This is just the institutions that are working with our group in many of the research projects that we are handling here in our research center. The structure of the lecture will be some objectives, the damage control concept in different areas, in general trauma care, pre-hospital care, emergency care, surgery, and perioperative care, and then the message to take home. So we all need to understand that to present the concept of damage control principles in trauma care are very important. We need to discuss and understand the impact of damage control strategies in the management of neurotrauma at pre-hospital and in-hospital level. We are going to review damage control surgical strategies in neurotrauma. We are going to frame the damage control process according to the level of resources available for neurotrauma care. So damage controls concepts allows for early restorative physiological conditions to maintain the patient alive, just to maintain the patient alive, focusing on fast interventions, preparing the patient for optimal and timing surgical care, and minimizing complications during perioperative care. So you all know that these strategies come from the military setting, and it was a concept that originally was used for war vessels that were damaged in the ocean, and they just do minimal fixations in order to take the boat back alive. So they don't do like a full repair of all the damage of the vessel, and they just do small controls in order to maintain the vessel floating. Damage control interventions across the field of trauma care allows surgeons and their teams to recognize that optimal combination of immediate assessment, resuscitation, and correct surgical early management techniques impacts the outcome of the patient. Military damage control intervention have been transferred to civilian emergency care in different specialties, including neurosurgery, orthopedics, vascular surgery, cardiothoracic surgery, anesthesia, and critical care. And the role of pre-hospital care and emergency care using the adjuncts of damage control techniques and the use of damage control in areas where resources are not abundant has changed the traditional management strategies of classical trauma care in the last 50 years. So let's talk about a little bit about damage control in pre-hospital care, specifically about neurotrauma. So when we talk about pre-hospital damage control, we need to focus on something that is control hemorrhage. We all know that even the use of tourniquets that in the past was not recommended, now it's recommended as a measure of control bleeding. Also, fluid management at pre-hospital level should be initiated using low volume crystalloids, keeping some concepts related to minimal crystalloid use, or the old concept of permissive hypotension that now is moving so to a small resuscitation volume strategies. Hypothermia must be managed, and these pre-hospital measures should not delay the transfer time for a patient from the scene to the hospital. So now to the traditional ABCDE process that has been advocated for many trauma courses. In pre-hospital, we always use the X before A, that is control of major bleedings. This is an example of one of the packages that has been promoted by the American College of Surgeons program of Stop the Bleeding, where you have your tourniquet, you can have gauzes, and also you can have some recent promoted specialized hemostatic agents that you can use since the pre-hospital area. So just to mention how this can be moved between the level of resources, we have here the basic algorithm for Stop the Bleeding in a trauma patient that is recommended by the campaign of the American College of Surgeons. And it's all depend of your level of knowledge, and you can even use tourniquets if it's required. But also you can move to more advanced techniques like the use of tranexamic acid at pre-hospital level, or even the use of pre-hospital plasma, especially the one that is dry with lyophilized access, and you need to prepare that in your ambulance or in your transport. But what have been seen in these recent studies is that the tranexamic acid really didn't do a change in the outcome of 6 months in neurotrauma patients. And it seems like the plasma could be something that will be useful in the next couple of years. We are all familiar with these bootstrap strategies that we have published a couple of years ago regarding recommendations for management of TBI patients in different settings, independent of the level of resources, pre-hospital emergency department, intensive care. This is the basic algorithm for management as a severe TBI patient in an ambulance where resources are very small and where the training of the people is really small. So it's something very basic, and it's focused a lot in control hemorrhages. Then if you have a more advanced vehicle, you can move to this other algorithm when you can start fluids, or you can start managing the airway according to the level of resources that you have, based always in those principles of small resuscitation strategies. Don't do it a lot of fluids, because all these interventions are going to have consequences at ICU or even at perioperative care. So we need to understand why, since these early stages, we need to be very careful with the strategies that we use for taking care of these patients. Then you move for damage control neurotrauma in emergency care, that also focus a lot in control hemorrhage, but with more advanced level, like in a shock room trauma level. We all are familiar with this new control, damage control resuscitation strategies that have been promoted for areas where they have been managing patients from conflicts. We all know that damage control resuscitation is now the predominant focus. Arrival in hospital, crystalloid delivery should be minimized, as it can be associated with a lot of complications in ICU, especially multi-organ failure and distress respiratory problems. Trauma-induced coagulopathy is a common problem caused by dilution and consumption of clotting factors. So early delivery of blood products is required in these patients. We just mentioned the possibilities of using dried plasma at pre-hospital level, and plasma will be more available at any kind of emergency room. So the general bed resuscitation strategy seems to be to have whole blood or other option is to have 1-1-1 relationship of blood substitutes, including platelets, fresh frozen plasma, and red blood cells. So this is a recent systematic review about the freeze-dried plasma for major trauma, and it really seems like a very promising agent where fresh frozen plasma is difficult to find. But if you have more resources, then you move to specific strategies that are based on more advanced diagnostic techniques like the thromboelastogram or the thromboelastometry, where you can define very early in your emergency room which kind of products does your patient needs. Now we are moving recently to algorithms based on thromboelastography or thromboelastometry, where according to the values of the test, you will decide if you use the frozen plasma or just cryoprecipitate or just platelets according to the test results. All these damage control resuscitation strategies have been tested since 2010 or less, especially in the military field, and now have been translated. We started using this approach very early in 2014. This is one of our first articles at that time, managing standardized trauma care protocols in emergency rooms. And then we test the specific use of those strategies in severe TBI patients. And you can see how the mortality was reduced in an important way at in-hospital discharge for TBI patients that were managed on according to these strategies versus patients that were managed before the implementation of these strategies. This is a picture of Dr. Juan Puyana, who is a trauma surgeon from Pittsburgh, who was my mentor and was the person who involved me in all these recent trials in one of our centers in Colombia. The bootstrap algorithms also have recommendation for emergency care based on these principles. This is the algorithm for managed patients in low complexity emergency department, even when in the absence of CT image. Or then you can move to more advanced strategies in centers that have all the resources. And if you see recently some trend of consensus, especially this one from the World Journal for Emergency Surgery for the World Emergency Surgery Association, there is a clear pathway of managing polytrauma patients with TBI according to the importance of the level of hemorrhage control and using damage control resuscitation strategy for improved outcomes. If we move from here to surgery, the damage control principles in surgery were established more than 20 years ago by this surgeon that is called Michael Rotondo. He was the first to apply these concepts in the abdomen, doing an abbreviated surgery performed on critical injury patients. Then Dr. Charles Rinker, who was a trauma rural surgeon, started teaching these principles for doing craniotomies in very rural areas where neurosurgeons were not available. He presented these findings in 1998 to the WFNS CNS section on neurotrauma and critical care. And then Dr. Jeffrey Rosenfeld, who is a very well-known military neurosurgeon, expert in TBI, started applying these principles also in rural neurosurgery in Australia. In 2004, a special issue of injury was performed in each one of the specialties performing damage control procedures at surgical level. And Dr. Rosenfeld presented the first paper about damage control neurosurgery, indicating that it's an abbreviated urgent neurosurgery performance on the injured patients to help to prevent secondary brain injury. Then during the Middle East conflict, especially during the war in Afghanistan and Iraq, some military neurosurgeons start applying these damage control principles in a specific course for non-neurosurgeons. And some of this experience was published in Neurosurgical Focus in 2010. This is one of the last articles talking about the topic that is from a group of neurosurgeons from Latin America, and including experts like Rocco Armond and Jeffrey Rosenfeld, who were leads or military management of patients in Middle East theaters, talking about surgical damage control in cranial neurotrauma. We talk about many principles, including the skin incision, how to take a better bone access, and how to implement this, especially in penetrating brain injuries. If you have more resources and you center, then you can move to more advanced setting beyond an ICP number, and especially focus on techniques that are developed in order to increase the capacity of the school for tolerate bigger pressure. And you can move for even fluid derivation principles like ventriculostomy or even cisternostomy to more aggressive pathways, including bone decompression. So it all depends of the resources that you have. Now we have a lot of non-invasive systems like the optic nerve ultrasound, the transcranial Doppler, and also the digital pupillometry that can be included into all these algorithms taking care of these patients, understanding when to move from very basic approaches to more aggressive surgical approaches during damage control processes in TBI. The Bootstrap also have some algorithms for ICU, even if you are in a very basic ICU or an intermediate care unit, or also if you are in a process of a more advanced unit with all the resources that were just recently shown in the past talk. Also, being in these perioperative care processes, we need to have in mind that fluid balance is very important related to outcome, because if you take care of the fluid balance at the pre-hospital level, or you take care of the fluid balance at emergency level, then why you don't take care of this at ICU when regularly you replete the most many of these patients during several days, when these patients remains very sick, and you start managing many of the different complications of the trauma patients. So this is something very important. This is one of the recent analyses from the Center TBI database that we all know that is one of the biggest database for TBI patients around the world, also with the Track TBI database. And they'll understand analyzing this data that in critically ill patients with TBI, there is a significant variability in fluid management, with more positive fluid balance being associated with worse outcomes. So these results, when added to previous evidence, suggest that aiming for neutral fluid balance or using small fluid resuscitation strategies indicating a state of normovolemia will contribute to improve outcomes of these patients. More recently, we have the possibility of also start understanding better the different stages during the damage control procedure for these patients, associated to the analysis of several biomarkers that are available right now under study. We know that also the Center TBI and the Track TBI programs have been very going real deep into the associations of different type of fluid or serum biomarkers in order to understand what are the specific procedures that have been happening in the patient related to different issues like vasospasm, brain edema, axonal injury, inflammation, neuronal cell death, and metabolic changes. And it seems like in the future, we are going to be able of measuring in real time what is happening with this patient and how all these approaches for better care are generating impact over the hemodynamic of each one of the patients. The evaluation of biomarkers also have been shown to us that every patient responds differently. And if you have a really good damage control resuscitation process at pre-hospital level or even an emergency room, all these curves move in different directions. So if you manage early the airway and if you really maintain really good pressure since the beginning of the injury, all the curves will disappear early during the days. But if you don't take care of the airway management of this patient, or if you didn't take care of maintaining really good blood pressure, then the curves will remain over time, generating more complications of the patient in all different scenarios that are related to secondary and tertiary injuries at the in-hospital level. We have been discussing the concept of tertiary injury. So when the people is not really well prepared or trained or didn't have all the resources, sometimes some management that are not really well established can cause more damage than benefits to these patients. I'm going to present briefly a case of a penetrating TBI following the discussion that Tariq present. We have a male with 22 years old, multiple gunshots with a 0.38 caliber in the head, in the heart, in the right and left lungs, and in the right lower limb. So this patient arrived to an ER in a basic ambulance after 10 minutes of the event. The ambulance performed a really basic damage control strategy, do not put in fluids, and also maintaining airway patency in this patient. The patient arrived with a heart rate of 140, a respiratory rate of 38 per minute, a systolic blood pressure of 50 millimeters of mercury, an SpO2 of 74%, with absence of radial pulse bilaterally. We all know that depending on the level of resources, in order to identify early shock, you can move from very basic clinical evaluations like the presence of pulse or not in order to understand if you need to move early to a damage control procedure. Or according to the resources, you can move to arterial blood gases to understand how very important markers like the lactate or the base deficit can be correlated with requirements of early transfusion, or just if you have thromboelastometry or thromboelastography, then you can move exactly to what your patient needs. Fortunately, this patient was really young and didn't have any associated comorbidities. Pupil was with a slow response bilaterally, the GCS with a motor response of 4, an eye opening of 2, and a verbal response of 2. This is a GCS of 8, with absence of respiratory sounds bilaterally, indicating the probability to have important damage, even a pneumothorax or even a hemothorax in both cavities, and also absence of heart sounds in auscultation, meaning also the possibility to having a cardiac tamponade. So it will be interesting to know, according to all the discussion that we have today, what will be your initial approach, even with the hemodynamic status of this patient at the emergency room arrival, with the management of airway and breathing, with the thoracic injuries, with the leg injuries, and with the brain. So when you have this kind of polytrauma patients, you need to rely on these damage control principles. So if you need to control initially the most severe lesions, you need to move specifically for controlling the area that can define life or death in this patient, that are the cardiac injury and also the lung injury. Maybe the leg injury, if is compromising a specific big vessel, also need to be managed immediately. So the brain injury management is not a priority until you control your hemodynamic status. You need to define if this patient is candidate for tranexamic acid at in-hospital level, or if this is a candidate of early transfusion in a 1-1-1 relationship, or if not, if you have access to a thromboelastography or thromboelastometry in order to define which type of blood products you need to start moving in this patient almost simultaneously when you go for surgery. So that was the portable chest X-ray of this patient. When you have an important hemothorax in the right side, fortunately the left side was not affected, and you need to take this patient, especially for emergency surgery, at thoracic level, and also to control the bleeding in the leg. So once you finish your cardiac surgery and finish to put in your chest drain tube and control the other hemorrhage in other areas of the body, then the question will be, what do you do next? So in this patient, we have a systolic blood pressure of 90 millimeters of mercury. We have pupils of 2 millimeters non-reactive, but the patient is already in mechanical ventilation. We have a GCS of 3, but the patient is sedated and intubated. We start the active transfusion of plasma red blood cells and platelet as a damage control resuscitation strategy. We also put tranexamic acid in this patient because he arrives in the first 3 hours according to the regular protocols of trauma and use of tranexamic acid. So then the question will be, you take the patient to ICU after the initial surgery, or you take the patient to the CT. So in this case, knowing that the patient was kind of hemodynamically stable and was with a specific damage control strategies during the perioperative care, we take the patient to the CT in order to understand what was happening inside the brain. So if we move to the Marshall criteria, we have a midline shift less than 5 millimeters, partial cisterna compression grade 2, and a bleeding less than 25 cc. So if you go to the actual scores that are not based on penetrating brain injuries, these scores are based on blunt head injuries. So it's not a good reflection to taking this score as a base for the fine prognosis of this patient. We understand that the mortality of this patient could be not as higher as we consider according to the findings. So then we decide if we are going to take the patient to an ICU and start monitoring, or we are going to just perform a small debridement, or we are going to drain the intracerebral hemorrhage, or we are going to perform a unilateral primary decompressive craniectomy, or we are going to tell the family that the patient has a bad prognosis due to the systemic injuries. So according to the experience that we have previously, and we just mentioned during this talk, we decide for doing a surgical damage control approach because the low availability of advanced neuromonitoring in a patient with important systemic injuries. So we need to know, according to the basic physiologic principle, that if this patient comes to an ICU, then we are going to need continued transfusion, and we are going to need to manage this patient with fluids, and the risk of hemodynamic distortion of this patient, especially with lung-hair and lung-brain interaction, will be very important. So we decided just to prepare the brain for a better approach and less possibilities of complications, because if this patient becomes really unstable, then it will be very difficult to take this patient to the OR for additional procedures. So this is a patient on day 10 after the decompression, managing with a few complications from the ICU perspective, and then you have the possibility to perform the cranioplasty after 1 month. So if you have more advanced technology, as we mentioned, more advanced resources for advanced monitoring, maybe PTIO2, maybe transcranial Doppler, then you can have a more delayed procedure. But even in those conditions, will be important that you take in mind that this patient have a lot of systemic complications when they're in ICU. So this is part of the experience that we are gaining and teaching to many neurosurgeons worldwide. We have open rotation for medical students, residents, and also we have our Global Neurotrauma Fellowship program, where we are trying to bring all these concepts from different scenarios, including possibilities of developing strategies for managing patients in very low resources settings up to advanced settings. And we just open this invitation to all of you if you are interested in participating in many of these educational experiences. So again, thank you for the kind invitation. We need to understand that emergency care is part of a regime of immense social importance, in which those who live and die are measured, and the political way of medical science interacts over the debate about healthy care provision in any society. This debate, with symbolic significance for any care in society, have political relevance and huge economic implications for the members and administrators of the society. That's why health education and research are fundamental elements to build appropriate well-being and social development in societies. And I think the process that have been delivered under the leadership of Dr. Borba with the Educational Committee is really important. And thank you for having this specific space related to trauma, because we all need to remember that trauma is the first condition that is surgically management in neurosurgical areas around the world, and also is the main cause of death and disability in young active population in near to 80% of the areas of the world that are the areas of low resources settings. Thank you so much.
Thank you so much, sir, for the wonderful lecture.
Thank you, Professor Rubiano. As good as always. Perfect presentation. Trauma is dynamic. See, the important to understand that our patient need intensive care 24 hours. See, to take care of the patient all the time. It's not like sometimes elective case that you do surgery, remove the, in trauma is completely different. The dedication from the first hour, see, is first minute, see, is very important. I don't know, Maria, if you have some questions from Professor Rubiano.
Yes, sir. So there are a couple of questions,
And
sir.
after you
First
can
of all,
go to the paper and leave Professor Rubiano to take a breakfast.
thank you so much, sir. Thank you so much, sir, for coming at this very early hour, sir. It's so kind of you, sir. I'm myself a huge fan of your work, and actually, I presented a review where I incorporated the damage control surgery. It is especially quite relevant to our setting in Pakistan, and you know, many of the cases are present to us late in our tertiary care hospital, where I belong to a tertiary care dedicated hospital, which is known as Punjab Institute of Neurosciences, from where I completed my own training, sir. But I have felt the need that there is, like you have mentioned very rightly, sir, that there's a need to train people to perform these surgeries as a life-saving maneuver in the periphery as well. And unfortunately, several of my own fellows who have completed neurosurgical trainings have been posted in the far-flung areas as a part of our compulsory job. If we get a government job, we have to perform at least 2 years in the periphery. So, sir, this concept really needs to be highlighted, and we can save so many people by implementing this very amazing policy. So thank you so much again. We have a question regarding the Campay's incision, sir. I know you have done that very well regarding this, regarding saving up of 2 vessels in the T Campay, but I would like you to kindly elaborate it further because it is a question by one of our attendees. Thank you.
Okay, thank you for the question. Yes, the Kempe incision has been uh, described, especially from the combat surgeons in Middle East theaters. And definitely what have shown is that decrease the amount of time for patients that are really sick and allow you to go to a contralateral site immediately for patients that have like blast injuries, and you detect different patterns of injury when you open the screw. Uh, now, in that paper that I mentioned to you about the damage control um, uh, concepts, we have the description of all the different techniques that can be used. There are recently important studies comparing the impact of the different type of injuries, and definitely is not associated with very high complications as was think in the past. So I think the incision that you perform, it depends of your experience. Now, a very useful incision also is a big posterior C-shaped incision that is used sometimes from vascular surgeons. So I think the type of incision, it's related to your experience, how you feel comfortable the most, and about the case. Because as I mentioned, sometimes we have these patients taken to surgery in a very bad shape conditions hemodynamically. So you need to do a really fast procedure. Is how to do like a decompression in maximum 1 hour or 45 minutes. So the incision will allow you to gain a lot of time.
Thank you so much, sir, for the wonderful answer. This was the only question we have got. Sir, we will proceed with a very quick oral presentation from 3 of our presenters. We have got Dr. Haider Suleiman from Pakistan. He's a PG training of 4th year residency FCPS neurosurgery. Sir, we will allocate just 5 minutes of presentation. We have got just 3 papers. Another paper is a recording that has been sent by the chairman of VANES Philippines, Professor Lynn Laudies. Unfortunately, she cannot be here because of another webinar that she has been organizing herself. So we will play the recording. So first, Dr. Haider, will you proceed with your presentation? You have 5 minutes to complete.
Thank you. Thank you so much for inviting me. Yes, I will be very quick. Don't worry. Let me share.
The play button.
Yes.
Which, yes. Yeah, yeah, exactly. Just the play button.
Do you have my screen now?
Yes, we can see. Yeah, just swipe.
Okay. Today, I will talk about the pattern and frequencies of traumatic brain injuries in motorcyclists in Pakistan. So introduction, first of all. Traumatic brain injuries. What is traumatic brain injuries? It is basically insult and disruption in brain functions due to external force, which results in various patterns of injuries. These various patterns including brain contusion, extradural hematoma, subdural hematomas, cranium fractures, diffuse axonal injuries, traumatic subarachnoid hemorrhage, and interventricular bleed. So basically, traumatic brain injuries accounts for almost 50% of deaths in RTA. Worldwide traumatic brain injury affecting more than 10 million people. This is the worldwide data from the different articles I collected. So we basically performed a cross-sectional study. Uh, this study was conducted in our neurotrauma unit, and all these the patients that were enrolled in these studies, their performance was filled by on-duty doctors, including their details about the neurological status, their demographic details, and any other injuries to any other part of the body, and radiological pattern of injuries which were diagnosed on CT brain. All these patients that presented to neurotrauma unit received standard treatment from their respective injuries. The different patterns of traumatic brain injuries that were diagnosed on CT brain were compared, and the frequencies were calculated. So total 174 patients were including in our study. Mean age was 27.86. All patients were male, and age was almost 18 to 40. CT brain shows highest frequency of brain contusion followed by the extradural hematomas and cranium fractures. So these are basically the tabulated form showing the number of patients and their percentage. So the brain contusions were among highest, and 57 patients, there were brain contusions, and followed by the extradural hematoma, almost 33 patients out of 174 having extradural hematoma, and later by cranium fracture, there were 30 patients having cranium fractures, and 21 patients having diffuse axonal injuries, 15 patients having traumatic subarachnoid, 12 patients having acute subdural, and 6 patients having intraventricular bleed. This is basically graphical presentation of the percentage of the different patterns we get in our neurotrauma, showing the highest is contusions, followed by extradural fractures, and so on. So basically, what we concluded from this study that motorcyclist head injury is a serious problem in Pakistan, and necessary action should be taken for the implementation of safety rules. Safety rules including that proper helmets, proper standardized motorcycles should be available in market. ABS brakes should be launched, and we should also launch airbags in motorcycle as well. This local statistic study will also help in spreading awareness among the motorcyclists to adapt the safety measures, and also help in the implementation of law and orders regarding the traffic rules. It will also predict the need for additional services and resources and stage for prevention strategy and guide health policies. Basically, this was the study we concluded so that we know that how much patients are getting head injuries and why they are getting head injuries, and what is the most common pattern of head injuries among these motorcyclists. So thank you so much for giving me time and presenting this data to you. Hello.
Hello, yes, thank you so much for your very nice presentation. Uh, Professor Parva, would you like to say any words? This is a very important topic in regard to our own Pakistani practices, since we have more accidents to saving in the younger age group from motorbike accidents. So this is
Yes.
something, this is a very huge problem in Pakistan right now, and there is actually the basic thing that underlies this problem is the lack of implementation of the safety rules and the traffic and strict traffic laws that should be there. So it is basically a preventable problem, a preventable thing through which we, if we simply take the step of implementing strict traffic rules and safety precautions, we can avoid several of the complications that we are having right now in the younger age group who suffer from the motorbike accidents. So this is why it's important. Thank you so much, sir. We have the next 5 minute talk recording from Dr. Lynn Laudies. It will be just a 5 minute recording.
I'm sorry, Nora, I don't have that.
Sir, I'm just playing her recording. She could not make it today. She's the president, she's the chairperson of the WINS Philippines.
Do you have the recording, Nora? I don't have it.
Can you see my screen now?
Yeah, it's sharing. Hopefully
Yes, I'm
it'll
sharing
work.
her
Hopefully.
presentation.
Looks good. No audio, Nor, no audio. You have to, Nor, excuse me, you have to screen share again, but turn on the audio. Okay, re-screen share, take it off the screen. Okay. You have to re-screen share because we're not getting audio. Yeah, get off the video, Nora, please. Okay. Leave it totally. Stop screen sharing. Okay, now re-screen share and turn the audio on. On the screen, it says accept sound. You didn't do it. Sorry about this. Nor you have to go off the screen. Okay, leave the screen and re-enter the screen and get off the screen. Stop screen sharing. Okay, I'm sorry I have to boot you off here. I'm sorry, folks, about this. Okay, now re-screen share. And when you open the screen, it says play video. You got to play the sound in the video. Okay, Dor? Okay, when you screen share, it says there's an option at the bottom, play sound. Sorry about this. Okay. Nor, what would you like to do? Okay, now when you screen share, okay, at the bottom of the screen, it says turn audio on. When you go to screen share, it says turn audio. Okay, now look at the bottom of the screen. It says turn audio on.
Yeah, yeah, I have Yeah, I'm trying to do this, but it's not working. I don't know. I have sent you
Okay,
this one as well. Can you play it on your laptop?
okay.
Let me check. Oh, no, okay, let me check.
Is
Can you hear now?
my short CV. This is my recently published paper, The Effect of Cerebrolizing in Severe Traumatic Brain Injury, a multi-center retrospective cohort study, published in Clinical Neurology and Neurosurgery this May 2022. The objective of this study was to determine the effects of cerebrolizing as add-on therapy to the standard medical decompression protocol for non-operative severe traumatic brain injury patients. It employed a retrospective cohort design, which included 87 severe traumatic brain injury patients with a Glasgow Coma scale of 5 to 7 on admission. These patients were non-operative lesions and were subjected to medical decompression protocol for severe traumatic brain injury. 42 patients received 30 ml of cerebrolizin per day for 14 days, followed by a subsequent 10 ml per day dosage for another 14 days. The control group included 45 patients who received the standard decompression protocol alone. Primary outcomes were patients achieving a Glasgow Coma score of more than or equal to 9 and Glasgow outcome score of more than or equal to 4 at day 21. Secondary outcome measures were the improvement of GCS at days 7, 14, and 28, GOS at days 14 and 28, and length of stay, and also 28-day mortality. Results comparing the control group, a significantly higher proportion of patients who received cerebrolizing treatment achieved a favorable outcome at day 21 post-traumatic brain injury, and a Glasgow outcome score of more than or equal to 4, 18% versus 39%. Mean length of hospital stay was also approximately 7 days shorter in the cerebrolizing group. And there was a significantly lower proportion of cerebrolizing patients with a length of stay of more than or equal to 30 days. In conclusion, for this paper, cerebrolizing is beneficial for severe traumatic brain injury patients with non-operative lesions, as evidenced by higher improvement in GCS and Glasgow outcome score and shorter length of hospital stay than standard treatment alone. Let us look at some of the graphs which were included in the paper. Take a look at day 21. This is cerebrolizing versus the control. It was already statistically significant in terms of the mean Glasgow Coma scale. The improvement was much better in cerebrolizing group versus the control group, and it was more highlighted at day 28. Taking a look again at the bar graph, from improvement of the severe to mild to moderate TBI, Glasgow Coma score of 9 to 15 over time, we already saw improvement at day 21 with the cerebrolizing group. Then here, the Glasgow outcome score at day 21 was also much more improved. It was statistically significant with the cerebrolizing group versus the control group. And here again, the improvement was at day 21. Proportion of Glasgow outcome score, again, between groups was statistically significant with p-value of 0.037 at day 21. So length of hospital stay showed that patients who survived up to day 21 had a mean length of hospital stay significantly lower in the cerebrolizing group comparing to the non-cerebrolizing group. In fact, all patients in the cerebrolizing group were discharged from the hospital within 33 days as compared to 47 days of the no-cerebrolizing group. We conducted a sensitivity analysis, and there was improvement in GCS from day 7 to 21. It was found significantly higher in the cerebrolizing group for patients less than 40 years of age. In terms of diagnosis, improvement in GCS was not statistically different between cerebrolizing and no-cerebrolizing groups among patients with diffuse cerebral edema, epidural hematoma, and subarachnoid hemorrhage patients. The proportion of patients achieving a GCS of more than or equal to 9 was only statistically significant between the two groups who were diagnosed with intracerebral hemorrhage. All cerebrolizing patients diagnosed with cerebral contusion and diffuse axonal injury achieved a GCS of more than or equal to 9 at day 21. In conclusion, this retrospective study provided evidence that there's beneficial effect for severe traumatic brain injury patients with non-operative lesions when given with cerebrolizing. Although patients without cerebrolizing also showed a significant increase in GCS scores over time, the improvement in GCS from day 7 to 21 is consistently higher in patients given cerebrolizing. Patients also showed faster recovery rates as evident by greater improvement in both the GCS and Glasgow outcome score and lower duration of hospital stay as compared to standard treatment alone. Furthermore, more than 90% of patients presenting with cerebral contusion, diffuse axonal injury, and intercerebral hematoma showed favorable GCS at day 21. Recommendations is that further studies should be exploring the long-term outcomes and cost-effectiveness of cerebralizing treatment among conservatively treated severe traumatic brain injury patients. I would like to thank you so much for your kind attention.
Okay, Noor.
Yeah, thank you so much. She couldn't be here because of her own conference. So we had her recording. We had a third presentation, but unfortunately, he had to. Our third presenter had to get scrubbed up on the OT, so we cannot play it. It was a very interesting one. Indeed. Thank you so much, sir. I think we should wrap up our webinar now. I would like to invite Professor Luis Porba to say some final words. Thank you so much, sir, for this wonderful idea and for the direction and supervision that you've been doing all the way. It's something really amazing and wonderful to provide this free web-based education to all the medical students and the residents. So it's a huge thing. This is totally a brainchild of Professor Luis Porba. I would like to invite him to kindly share a few words to wrap up the session.
Okay, Maria, always a great pleasure to participate, to help in these webinars. You are doing a great job. Thank you, John, for our tireless work. See, wake up 3-4 o'clock in the morning almost every day to do the neurosurgical education. The work that Dr. John Bennett is doing this last 3-4 years is amazing. He started, I think, 4 or 5 years ago. You remember, was few people participate. Now you take over the whole world.
In Russia.
Yeah. Now the people is listening and watching your webinars worldwide. Thank you, John. Thank you, Maria. Let's continue. Let's educate the people. Let's bring the real neurosurgery alive. Let's bring things that you love to do. It is a great time here. Thank you. See you next time, maybe next month. Okay.
Thank you, sir.
Thank you, Maria. Thank you all. Bye-bye. Thank you.
Bye, sir.
Okay, Louis and Nora, we're not letting you go. We're going to have you back in a few minutes to the next broadcast on the surgical anatomy of microneurosurgical. So just a few minutes, we'll see both Nora and Louis.
Yes, we will be here. We will be here. And everyone, please stay here.
With Professor Guilherme Ribas to talk about the anatomy of sulci